Well, our shared care site was a vision that Dr. Shaker had, and he hired me to help him with that. So for about the last 2.5 years, we've been working towards that. I am certified in heart failure. I am a VAG coordinator. Um, so it's just it's a grow. You know, we've grown and we're kind of changing as we feel like we need to.
I think both patients, caregivers, and doctors need to recognize that heart failure is not something that's going away. It's a chronic disease. It's not something that's a quick fix, and that's one of the big problems that we face, because even most cardiologists look for something that's a quick fix. Can I get somebody have a stent, or somebody have a defibrillator? Those are all crutches. Patients with bad hearts do need a defibrillator, but that's not going to make them feel any better. Right? All it will do is avoid their having sudden cardiac death. But in terms of quality of life, in terms of these patients being able to carry out their normal activities and be able to go visit their grandkids, those are all things that they're all restricted in. And so it's something that they all have to recognize, whether it's physicians, whether it's patients, whether it's caregivers. People need to realize that they are a lot sicker than they admit. And a lot of patients with time, they begin to think that's what their destiny is, and they think that's what they have to be. And most times they don't. As we advance in most therapies, being aware of it is the problem for most people.
So, what I wanted to do today, just to kind of give you an overview of what this next hour and a half is going to look like. This is very laid back. We want it to be very interactive and really be designed around you, your interests, have an opportunity to meet other patients as yourself, and also to talk about what shared care actually is. And we actually have a local cardiology group that's participating in shared care to help support. So it's been a tremendous growth on a lot of different scales. So what I would like to do, because I've spoken with all of you, but I really don't know your background. So what I'm going to ask you to do is we go around the room and please just share your name, what center you had your device implanted at, and then how long you have actually had your device today. And so I'll start here to my right.
Jerry Duggar, Waterhaven. Tampa put it in for me, Dr. Caldera. I've had it for 14 months now. Well, once change out on the controller about a month ago. Other than that, it's just aggravating.
Yeah,
You get used to it.
beats the alternative.
I've tried.
No, I meant, but you do get used to it. One of the hardest things I found, and we'll get back to this in, is getting out of chairs, out of my recliner, because the batteries slip back and I'm out of weight. Balance, but other than that, few minor inconveniences.
Well, I haven't learned to balance myself yet.
Oh, I know. I mean, I had no balance with myself either, but so beforehand. So I mean, it's the little things. But I mean, you get used to it.
And Mr. Durr, what was your situation prior to getting your HeartMate 2?
Heart attacks. I've had 2 bypass surgeries. I'm on the 7th pacemaker. Second one, the last 2 are defibrillators. In my heart, it got down to what, 10%, way down low. So they put this in and got me some blood flowing. So,
Did you have a lot of time to make a decision?
yeah, I went over there and talked to him. I said, I'd like to have this done in November. Well, this was in July, and he reaches in his pocket. This is Caldera now. He reaches in his pocket, gets his calendar out, says, "Oh, I got to open it Tuesday."
Well, see, I'm a totally different.
So he put it in right then. I'm glad he did, because I thought I'd recoup a lot better than I did. I had a bad time recouping from it. I couldn't stand up, I couldn't get up, you know, couldn't walk.
Amen.
So
And how is it now since you've been 14 months out?
it's a lot better. My legs still give me trouble. And where they, 2 bypass surgeries, the right leg, or excuse me, both legs have been cut so much for getting arteries out. Phlebitis twice in this one, so it contributes to the trouble.
And then have you been able to travel?
Oh, yeah.
So your lifestyle has gotten better since would you say your lifestyle has
Well,
changed?
we were
since
traveling to death. Yeah.
I would tell them to be more inquisitive than I was, because I found out there's a lot of things that go on that you don't know about until after the fact. And for instance, this controller is hot. And you wake up at night and you roll over on it and it wakes you up. Well, you got to move it. So, you know, it's just little things.
My name is Jackie, and I'm Jerry's wife, and I'm his caregiver. It's been a change of life for us. A lot of scheduling. I do, you know, all of the reordering of all of his supplies, so you always have to make sure that you have supplies. And I will say that there's been no problem in getting supplies when I needed them. Scheduling always his dressing changes, and so it's been more of a balance of our lifestyle, making sure that you know, that I'm there, you know, to be able to put the bandage on when he takes a shower and the dressing. He more or less takes care of all of his the log work, you know, putting in his all the numbers for his log. Now we have just received all the equipment for telemarketing, and that's where there's a special scale now that activates his, you know, the weight, and he takes his own temperature. I now have to help him with the blood pressure, but all of that goes to a leader, and then they in turn give all that information to Tampa, so that when we're here, the weekly visits to have his blood lab work done can all be now done through the house, so we don't have to go off.
Well, everything except blood counts. Just the INR and everything. I'll have a blood work.
And you can petition to get that after a while, and
It's
do it
on its
yourself.
way.
It's on its way. We just don't have it yet.
Just got to be careful with your strips.
They're expensive.
They charge, because on the thing, if you send in, it asks you how many strips you use, and you get charged for every one of those strips you use.
Yep.
So if you have a bad week, a bad day, you might, if you use 3, you're getting charged for 3. That
Right,
week.
right.
I'm getting accustomed to it after a year, and I'm doing now what I was doing before. It's just, you got to be more careful, because you know, you shower, you just don't go jump in the shower or run out in the yard. You always hooked up to this battery with you, and which is a restriction. You know, you get in the car, put the seat belt on. Well, you get out of the car and the seat belt's wrapped around the battery, and you tug of war. You don't get close to a doorknob.
Right.
How many they send you?
10.
10 at a time?
Now, we were told more than that, huh?
The box, the machine I have in the box I get 10. But I very rarely, after this length of time, have any problems. Every once in a while I'll screw up or something, but so it normally lasts me like 3 months. So 2.5 months.
So anyway, you know, just making sure that we made one trip. We have a little place up in the mountains, and got half halfway, well, we got up there and only discovered that we had forgotten the black bag. So we looked into having it shipped up to us, UPS, overnight.
Friday.
And, you know, all of them had said, you know, well, it's, because we're way back in the mountains, and so it just so happened that we had a cousin who was coming up for a funeral, and so we were able to meet him up there and get our little black bag back. But for the longest, we you know, we had to put the black bag right by the door so we would remember, you know, to take it with us.
I'm Connie Raxton. I'm caregiver for Mark, but I don't really do much besides the dressing and help with the shower and stuff like that. He does all his own paperwork and
Gotta do something.
there you go.
Sorry, Phil.
I'm Mark Ragsdale. I've had it for 4.5 years from Tampa. I was one of the first ones that got it in this area after it was approved for general use. And thank you, you and Dr. Ahmed. I really do appreciate it. Okay, I was a crash and burn. My heart was down to 3 on the scale. I was in a 55-day drug-induced coma. So some of this stuff is still strange to me about you being able to go in and talk to a doctor about having one done. I just thought people were nuts because they kept every once in a while tapping me on the shoulder when I was in the coma, going, "You're in Tampa General. You're in Tampa General." I'm going, I don't know. So, but I mean, so I have a lot of this stuff is still strange to me to hear people be able to schedule your appointment and this kind of stuff. All I remember is passing out here at Winter Haven, and Dr. Ahmed, my doctor, found out about this and they convinced Tampa to do it for me. So I thank them for that, and I've had no problems with it at all, and I'm happy with my lifestyle. The only thing is, some things just take a little longer. It takes a little longer to take a shower and a few odds and ends, but it's a state of mind. Every day's a good day. Some days are greater than others. So you live like that, you're okay. I can give, if you do it, get it, and follow the doctor's advice, I think you'll enjoy it. I was not one of the lucky ones that was able to discuss it beforehand with the doctor. I was a crash and burn. So I woke up after about 60 days total in the hospital having something inside me that I didn't know about. But that's not against it. I mean, I'm happy with what I have, but I did not have any prior knowledge of it. So I mean, it was kind of a shock for me to wake up and find this on. But as long as you follow what the doctor says and the company, I don't think you will have any major problems. And if you have a willingness to change some of the minor things in your lifestyle, like used to I could take a shower in 15 minutes, now it takes me 45 minutes to an hour. Little things like that. I can't lift over not supposed to do stuff over my head and stuff. So I mean, it's the little things. But if that keeps me here on earth, I'm happy. It could be a lot worse. I want to see my family. My family, there's certain things I want to see in their life before I pass on if possible. So that, and every day's a great day. Some days are greater than others, but every day is a great day. And if you can keep that philosophy, you can make it anytime. Okay, I did not feel too much. I did not feel sick, I'll put it that way. I was a manager at a fast food business, one of the busiest ones east of the Mississippi for a major chain. And 65, 70-hour work weeks were not uncommon. So I did, and I was still functioning. So I really didn't notice anything so it was kind of, when it hit me, it hit me. I was approved. I turned it down. They keep asking me. They didn't ask me for about 2.5 years, and then in the last 6 months, they keep asking me. My numbers are very good. Everything is good, and they say I'm a good candidate. But I'm happy where I am, and I feel since I'm functioning, and there's other people that can't function as well as I can that would be on the list, Well, considering I was told that they were trying to keep me alive till my daughters could get in from Oregon, and that was in March of 2010, and this is now September 2014, I believe it's a life-saving thing. It is an option for those that do not qualify or are too old to have a heart transplant. So it's another viable option for people to live a little longer as long as they take care of themselves.
My name's Donna Smith. I've had my VAD since February 13th of this year. I was going to a doctor in Kissimmee, had been going to him for years. I was in the hospital twice in November and December for 6 days. They couldn't figure out what was going on. They thought I had pneumonia. They treated me for that, and come to find out they didn't know what was going on. My sister, I had to move in with her. My mother was diagnosed in November with breast cancer, and I lived with my mom. And my stepdad had COPD. All of us at the same time were really ill. And my sister, I had to go stay with her because my mom was sick and needed somebody to take care of her, and I couldn't do it. I couldn't walk from here to the chair they're sitting in over there without just about passing out. So in February, my sister, or the last week in January, my sister said, "You're going to the hospital, get up now." So we're going to Winter Haven, you're not going back over there. So we went to Winter Haven. Dr. Gibbs, I think it was, is who admitted me. And they kept me in intensive care there for 5 to 6 days, I can't remember exactly, and then they shipped me to Tampa by ambulance. I had 10% usage. And they did the surgery the next day on the 13th. The following week on the 21st, my mother passed away. I didn't get to go to the funeral or anything, but God had his reasons. I accept that because I know God kept me here for a reason. I've done real great. I haven't had any problems. Till yesterday, it got really sore around the drive line. I called them. They wanted a picture sent, and they said it looked like the beginning of an infection. They gave me antibiotics, told me to come in Monday for them to look at it. But if it was better to call them, and I'm believing God for that. I ain't going to have to go Monday. But God's brought me a long way. I ain't had no problems, except this little bit of redness around it now. But other than that, I walk a mile with my daughter-in-law around the Winter Haven walking thing every other day or so. And she's pregnant, so she's walking, and I need to walk, so we go together. But I'm happy with my VAD. They approved me for the list 2 weeks ago, and I turned it down, told them I was fine, that I was going to live till God got ready for me, and I'm living a good life, and I don't want to go through that again. And that's just the way I feel. I'm doing fine like I am, so we'll leave it there.
I did. I had someone that done that with me.
Oh, so okay.
A man from Miami. He was in the hospital, I guess, for an infection or something when I was over there, and they brought him up to talk to me, and it encouraged me.
It did.
Yeah, because I was afraid. I was very scared when this was going on because I knew that the alternative was either take the surgery or die. There was no getting around it, you know. And I said, my grandbabies are just still babies, and I want to be around for them, you know, to see them grow. And I got another one on the way, so I want to be here for that. But yeah, it encouraged me to talk to somebody that already had been through this process. Two weeks ago, they told me I'd been approved for the list, to be put on the transplant list, and I told them, I said, is this my decision, whether I do the transplant or not? And he said, well, sure. It's you, so it's your decision. I said, well, I choose not to. I'm healthy. I'm doing everything and more than I done before I had this surgery. And I feel good. I can play with my grandchildren. I can walk with them. I can let them ride bikes. Before, I couldn't even go out the door with them. So I said, if I have to go through the surgery again, I'm going to be laid up for months, and I don't want that. I said, I want every minute that God allows me to have my grandchildren's company and for me to stay here and watch after them, I'll be here. I said, God says when I leave here anyway, not a doctor or not no man. So.
Great story. Thank you for sharing. What I'm asking is that you introduce yourself.
Okay.
Let us know what center you had your HeartMate 2 implanted at, and then how long have you had your device?
You go. I'm not
You can tell him your name.
Robert Muggle.
Hey, how about that? He's had a stroke since he got the VAD, so he's a little bit nervous about talking because he forgets things. But I'm Aldina Muggle. I'm his caregiver, and he's had the VAD 5.5 years, and he was down to 5%. Squeeze rate, I guess you call it. And we had gone to Dr. Owens in Lakeland, and he's been taking care of him for about 20 years. And he said the only thing available would be to help him would be the LVAD. But he wanted a heart, so we went to Cleveland Clinic for 4 days, and they checked him all over, evaluated it. And they said the only thing they would suggest was the LVAD. So he was in the hospital in 2009 about every month, one hospital or the other hospital, wherever the ambulance would take him. And then finally we went to Tampa, and Dr. Sheffield said that he was too sick to put the VAD in. So they had to leave him for about 10 days and just try to build him up. And then they did the surgery, and he's doing well. He has an infection, but every so often they give him the antibiotics, and then they stop him. They can't give him all the time. So he doesn't.
Infection
In the driveline,
oh,
around the driveline. Something started to grow, like a tag. They call it a tag, and they cauterized it, but it came back, and I don't know if that's causing it or what, but he gets built up, and pus and everything comes out on the dressing, so.
what was your infection?
Around the driveline.
Yeah.
What was it? Did they tell you?
They don't know. I gotta go Monday. They just sent me an antibiotic prescription.
Well, they took a picture of mine and sent it to Tampa, and they said I got a yeast infection.
That may be what mine is, I don't know.
Yeah,
not sure.
They really haven't told me. They just said that ciprofloxacin is the only thing that'll work on that, and they don't want to give it to him all the time, because then you'll have an immunity to it.
Yeah.
So we're dealing with it. He's had it about. It was a year in April. He's had this infection. It was little.
Oh gosh.
It's been building up. It's quite large now. He gets it on the outside of the dressing and everything, so. They suggest you just,
We haven't had, I mean, I noticed something, it wasn't right where the power cord is, but it was just right on the outside and became redder, larger in size. And we were just over to Tampa last week for a general checkup, and I wanted them to look at it because it was growing,
Yeah.
but it wasn't the pus and all that, it was just a red, and they
Redness around,
they
yeah.
said that they felt like it was a yeast infection because a lot of times it gets damp, or if he's, gets
Yeah.
hot and sweaty, that, with the bandage and everything. So we've been told to go get just over-the-counter monostat and just put on it.
Now, I have something similar to that, but it's not under the bandage area. It's right on the other side. Cause I'm one of the first ones that had coming out on the left side. So I've had some nurses tell me at Tampa that it doesn't come out on the left side, but I had to explain that to them.
It does come out.
It does come out. I mean, I kind of know.
Yeah, because they ever did to yours, yeah, it comes out.
Yeah, because he can get a little extra cord inside you, so that if he has to do something, he's got a little leeway. That's what the problem is. But I've noticed if I do something strenuous that I really shouldn't do, like vacuum when I broke a bottle of curry powder on the floor and couldn't stand, and nobody was home, so I vacuumed. The next day, I get a little red this way, and I hurt. But then a day later, it's gone. But
Why does that hurt you?
I have no idea. But I mean, if I do a lot of bending and stretching and raising, that will hurt me, and then it goes away. So you might be lucky on that too.
You know, you're not supposed to do this.
I know that. I know that. But every once in a while, you got to do something. You know, if you're the only one around the house. It's like I wouldn't have vacuumed if she had been there, but I couldn't stand the smell of the curry powder all over the floor for another 6 hours before she got home. So I mean, it's little things like that. I mean, I know what I can do and not get it. But then there's some days, or if I go shopping or do a lot of picking up, or if my grandson's there and I pick him up some, which I really shouldn't do anyway, this kind of stuff, the next day I'm a little sore there. So it might be that, because it kind of feels like a finger or something inside. Is that?
I've never had a pain on it, never on it.
No, it's just a little, it's like a little redness. And
Yeah, I
it's
mean,
not,
mine gets kind of big,
no,
not like
ours
this,
is more
but I
of
mean,
it started out like the size of an end of a pencil eraser,
yeah.
and now it's probably the size of a quarter. So I know it's something that's growing there.
Well,
and
mine will
that's-
get based on that, and then, as I said, after it gets through, it's gone. I mean,
It's
I don't
not-
have any
Well,
trouble.
I've never had a problem with it, except when I dropped the bag one time.
How many years have you had it?
14 months.
14
Yeah.
months.
See, you're taller than me, so you have a problem if you drop your bag. My cord's okay if I drop it, because I barely touch the floor with it.
Oh.
So, I mean, I've had the,
Well, I
So you
had
have more of a.
I had it in the shower bag, and
Yeah, it wasn't, yeah.
that's
Anyway,
smart.
yeah.
do you have the big square shower bag or the little one?
No, he has
Yes.
the little
Really?
Fairly little,
Yeah.
but it's, you know, everything in it.
Oh, but I mean,
It's
did you ever
heavy.
have the big one?
Uh,
Oh, you don't know how much better you got it with the little one than you did with the big one.
I tell you.
I mean, the big one was like this and like this, and it was, you had your thing like.
You got your
it said
batteries on each
battery
side.
side, and then
Oh,
that,
and you
and
got
then it was
the-
a big plastic thing. I mean, it was at least this big.
We hang ours on the faucet. It's,
We had a soap, a bar in the shower that happened to, and we were able to hang it on that.
yeah.
But now with this other one, I can do it without that. I mean, it's not too bad. Hey, you don't know how good you got it with this new stuff.
As I said before, you know, with so many patients now getting the device, one of the things that the company was approached about, we kept getting contacted by patients saying, well, especially the destination therapy patients, saying, was there someone local that can see us? Because, you know, once you get out to a certain point, you know, we found out that a lot of patients were going back to the center for well check visits. And so for some patients, you know, driving hour and a half, or even much longer, depending on where they're at in Florida, that's how shared care evolved. And so today we have over 144 shared care sites throughout the United States. And here in Florida, Winter Haven was the first community-based shared care clinic. So, you know, they felt that it was very important not only to continue the care of patients in general heart failure, but more advanced heart failure options, such as, you know, having an LVAD or a transplant. And so they went through a process where they began to do their own research. They went to training. They partnered up with the centers to be able to understand how the centers are managing patients, what things that they should look out for. And overall, it's been a great experience because, number one, it sounds like from most of the examples here today that everyone here was pretty much a last-minute referral. It was an emergent situation. And by having a shared care clinic now that is spending more time in understanding patients and when patients should even be having a discussion about this advanced therapy, is creating an opportunity to get that information to families much earlier on in the process instead of waiting at the very last minute. So what I would like to do is introduce Cindy and Dr. Shaker, and they can share with you a little bit of what they have currently done and how many patients they're following. They're currently partnered with 2 transplant programs, Shands in Gainesville, Tampa, General obviously in Tampa, and soon to be Florida Hospital. When we look at Florida as a whole, there are 6 implanting centers within Florida. And so right now, they're soon to be online with 3 of them being able to open up. Well, 8 centers that are totally implanting, but when we talk about transplant as well as VADs, there are 7. Okay, 7. That's my clinical, so she keeps me on task. So with that, I'll introduce Cindy and Dr. Shaker.
Hi, everyone.
Hi.
Hello.
Hi, I'm Dr. Chandrasekhar. You don't know me. Mark knows me.
I kinda
barely,
know.
barely.
And I did see you one time right after that
That's
at your
very
son's
true.
graduation.
That's very true. Actually, I tell everybody, you're my favorite story because you're the reason I got interested in VATS. Because when I was on call on the weekend, and he had come to the hospital with a massive heart attack. He had had a catheterization. He was inoperable. He was on every tube known to man. He was looking very sick. And my sign out, which was very easy, was just saying, "The man's not going to make it. Just go put a little note, and you can get out of there." So I went there and I asked the nurses. They said, "Well, waiting for something until everybody agrees, we'll turn off everything." So I go there and say hello. I didn't expect him to talk back, and he actually opened his eyes, looked at me with all these tubes, and I said, "Hold my hand," and he did. And so I came out and I said, "Why are we letting somebody die if he's still alive? He seems to be in reasonably good shape otherwise, other than this."
Can I, the reason, what I was told is you all were originally just trying to keep me alive till my daughters could get here from Oregon. That's how bad I was.
That's exactly right. That's what I was told. I was told we're keeping him alive until some family members come. And I said, this makes no sense. So then I spoke to Dr. Ahmed. And I said, why are we not trying to do something? And poor Dr. Ahmed said, what do you want me to do? You're the heart doctors. If you say I can't do it, there's something. I've been thinking the same thing. And so I said, let me make a call. And so that's what I did. I spoke to Dr. Kumar at the time. And I said, I have this gentleman. I think, he's pretty sick. He's on a balloon pump. He's on all these drips and he's intubated. But he's still alive and he's still, he responds to me. He squeezes my hand. And so that's what happened. And then thanks to, I believe, because of the insurance and so on, it took another 3 or 4 days for you to physically go. So by that time, I was thinking, did I do any good? Because I spoke to you, and I said, did I let the family's hopes up? We spent an extra 4 days, twiddling our thumbs, waiting for him to physically move. And so after that, I didn't hear from you until I saw you at my son's graduation. And all I could remember, of you was you were in a wheelchair with a mask and a hospital gown or something like that. And you said something like, Dr. Shaker, thank you, or something. And I'm thinking, who are you?
Yeah,
I don't know.
I can see the blank look on your face.
Very much so, because when I saw you, I hardly ever saw your face because you had all these tubes sticking out from
and
the
also,
bottom.
I did not want to interrupt the reason you were there for your son's graduation.
That's right.
I was attending one of my employees' graduation from high school, and she wanted me to show up very, very bad. So I did force myself to go. It almost killed me, but I did show up.
You did. And I said, who is this person? I don't know him. And then I met you, and I said, I know this woman from somewhere. I don't remember who she is. I know, but I haven't seen her. Whoever it is, it's been more than a couple of months, is what I was thinking. And then later that week, Dr. Ahmed came to me and said, congratulations, your son is graduating. I said, that's true, but how did you know? And he says, I ran into the Ragsdales, and they told me, who are the Ragsdales? He says, he's the gentleman, remember, we sent to Tampa, and the rest is history.
Now, the reason it took so long to get me there is because this was such a new thing.
Yes.
It was not coded into any insurance.
Yes, I know.
And actually, I almost about ready to tell you I'll take this thing out when I got my first bill from the hospital, and the insurance disallowed it. And I won't tell you how much it is, but I was in a coma for 55 days, so you can imagine what my bill was.
Right.
Okay, so then they went on and they paid it all, but I mean, it was so that they had no idea how to code it out. That's how new it was. There was nobody in the state of Alabama, of Georgia, that was authorized to do this procedure when I did it. So I thank them so much for doing the research, and I thank Tampa General.
I think if you see, not only in this country, but in most places, people think of the patient with advanced heart failure as the one who is in the hospital, usually on an inotrope, sometimes on a balloon pump. Patients who are very, very sick. And those are the patients who actually are in the stage of crash and burning. Those are the patients who probably won't make it despite the best of therapies. And so the key has to be to recognize these patients before they get that sick, because then it gives the patient, the caregiver, the implanting center, everybody the luxury of assessing the patient, getting them optimally into the best shape they can be. That's a big, big plus. And you see a lot more patients who are at that edge where they are so easily fatigued. So often they keep coming back to the hospital, and sometimes, very often this is missed because one admission is called heart failure, another admission is called pneumonia, third admission is called COPD, and so forth. And then sometimes they have, many of these patients with bad hearts have sometimes a temperature spike when they come in with this acute exacerbation. So therefore, everybody assumes it's a bad heart, that it's infection that's doing it. Some of these people have some elevations in their creatinine, and therefore people think it's their kidneys that are failing. But all of it is very often just the heart. So if you get them quickly before they get to that stage when they are symptomatic with just minimal exertion, if they are not able to carry out, that's the stage when they should be looked to be sent for advanced therapies. And so that's how I got interested. But then I've had the heart failure clinic for much longer because, as you pointed out, one of the most common things that happens is that people go to the hospital or to doctors, and almost always, it's pneumonia or it's bronchitis, and it keeps going on. And most of the times, you've smoked before, so it must be bad lungs, and so on. And same thing happens at the hospital. People get admitted all the time, and nobody thinks it could be the heart before you end up finding it. So that's why I've been doing this. And then since your case, then I've been more interested in VADS. And then since then we've been working with Thoratec, with shared care. And with shared care, we've had these patients who go to Shands or Tampa. And one of my other concerns has always been, we have patients from here. It's not easy to keep driving back and forth. So, and that's one of my big pushes. And I've been talking to the hospitals and saying, it's not just with VADS, but in general, people with bad hearts who are on infusion pumps or transplant candidates and so on, to be going back and forth for things that can easily be done here makes absolutely no sense to me. And that's why we have one of our patients who was a bad patient from Shands. The last time she had a problem, came to the hospital here and said, I want to stay right here. I'm not going to drive all the way. Dr. Shaker can take care of this. And so she said, it's not related to my VAD. I'm short of breath, but it's related to my COPD, and it can be managed here. And she insisted on staying. And that's kind of what I've been trying to push, that we have the patients taken care of, unless it's something that absolutely involves the drive line. The drive line has to be replaced or something. That's a different story entirely. But it soon becomes that for an ingrown toenail, you end up having to go all the way, literally, because of the fear, because nobody will want to touch. That's the problem.
I had some teeth done and I had to go there.
Yeah. That's exactly my point. And Cindy will tell you with her experiences too.
We follow patients that are just like you. We can do the well visits, and we've also run some interference for some problems, and actually have coordinated the care for the patient, the hospitalizations. We work very closely with the centers, and they kind of, that's the shared care part. We decide what to do for the patient, and we get it done. So for some of the patients who are being considered for LVAD or transplant, we sometimes work with the implanting center once they're established patients with them. A lot of times they need nutritional support, or they may need certain testing to see if they qualify for these advanced therapies. So we coordinate that, and we're able to do that locally, and that keeps them from having to drive and do all this workup And then once the patients are implanted, we can actually coordinate their lab testing. We can review that. If there are problems, we coordinate that or talk to the centers. And if there's anything that we need to do, it can be done here locally.
Like the
And it
patient
works
was
very
anemic,
well.
Like the patient was anemic.
Mm-hmm.
You know, that's the reason why the VAD was.
So we catch the problems early, and we talk to the center, and we've really, it's worked well for the patient
And for them, because instead of having to go there and we check here, you already have everything done, so the information is there.
and referral.
Yeah.
We have patients that are very sick, just like you, who we've sent early, and they haven't had to go. You know, they didn't have to be on a coma for 54 days.
Yeah. That's the whole push, as you well know. You don't want the crash and burn. You want the
Exactly.
people who are way before that. And that's one of my biggest peeves, because a lot of times people with bad hearts, if you think about treating heart failure, right? The easiest is treating the symptoms. You know, somebody short of breath, you give them a little diuretic, their fluids out, so now they can breathe. That doesn't mean you've treated anything, right? So then the next part is improving their survival, so you can put them on the right medicines and so on. The problem even with that is most doctors do not put them on the right doses. You know, everybody will put them on enough so that it looks like they're being treated, but they're not on optimum doses, because it takes time. It takes time to regulate it. You can't just put them on a high dose to start with, so you got to keep seeing the patient, seeing how they're doing, and so on. And the final part is nobody worries about quality of life, because the problem with most heart patients is if you look at them, they look fine. And that's why, you know, it goes on till you get to that point where in your case it was a heart attack, but in general, most people with bad hearts, you wait and you end up waiting because the doctors and everybody thinks this guy looks too good. Because in the little time that you go to the doctor's office and you say, how are you feeling? I'm feeling fine. But then only when you ask, you know, recently I had a patient who came with a ejection fraction of 20 and said, how are you? I'm fine. Then when I ask him, how much does it take for you? What can you normally do? How much could you do before? And then when I said, how about when you go shopping? What can you do? And so I said, how about when you go to Walmart? And he said, well, if I'm just going and picking up one thing, I usually can come out. But if my wife has a few things she wants me to buy and I'm walking around, I got to stop a few times. I said, you're 55. Why can't you just do all that? So, oh no, if I do all that if I'm rushing, I get very tired. I get out of bed. I have no energy. And that's very common. And it's trying to detect those patients before they get to that point. That's where it helps the most. Then you get those patients to see us. That's when we send them to TAMPA or SHANS, when we think they're getting to that point where their ability to do anything is being compromised. And I think you see a lot more of that too. You know, a lot of those patients that come in there because you spend a little more time with them, and then that's when you realize they're having trouble doing something.
And even after we send the patients for referral, some of the patients need nutritional support, they need some optimization of their medications, they may need to be on some special medication, inotrope therapy, to kind of build their heart a little bit and get well enough to get the VAD. Because we know that people who are optimized, even if they're very, very sick, will actually survive the surgery. Their
Much
outcomes
better
are much, much better.
Than
So-
somebody who's very sick.
Right, right. So that's what we do. A little bit of what we do.
We were over in Bartow and we're having lunch, and just as we were walking in, there were some EMS gentlemen coming, and they said, "Oh, you have the VAD." So are you in the training aspect?
We help to coordinate, when we have a new patient, we help to coordinate the training
about
for the EMS,
Is
the
that
local
more
EMS.
prevalent, in Polk
It's
County?
actually
Because-
for the EMS that would respond to your home. So we kind of try to figure out who it would be that would come to your house if you had a problem, and we train them to know exactly what to do in the case of an emergency. And the ER as well, the local ERs.
Because when I got out, nobody in Polk County, no EMT was trained.
Right.
And they wouldn't train because we went as far as a friend of my sister-in-law was friends with some big shot in the government, and they ran this thing, and they would not approve being trained for LVAD.
Part of the thing was that
We were so rare.
We're
I was
so new.
I was
So
the
exactly.
only one east of. Well, he wasn't out of hospital quite yet. We were the only ones east of Lakeland. in Polk County.
You're a
so.
trailblazer for sure. You're the poster child for how good things can turn out for a patient.
But the flip side is that we do want that we don't want to have to wait until you reach that
Exactly.
stage.
And
We
we
try
I
and catch you
understand
before.
it because even Tampa was telling me they do not want to do too many more crash and burns
Yes.
Absolutely.
because the family will promise everything in the world to get it done, and then they don't follow through. They sometimes don't even see the patient again for a year or two, and they try to track them down and they can't find them.
Right.
So why spend that kind of money? Why get them?
Absolutely.
And I'm not. Life is precious. I'm not saying that, but if you're not willing as a caregiver to do what you said you would do to keep him alive, then why do it?
Yeah.
And that's what they're doing.
And it's very difficult, especially if it's a crash and burn patient, because there's a lot more that needs to be done for
But,
them.
but
because
Susan and them will tell me and Dr. that they don't really want to do too more crash and burns because
Yeah.
they were.
And the outcomes are not as good.
Oh, I know that.
And
but
that's
also,
where we come in. We kind of like recognize things early so that we can avoid that. And you know, the time is precious. We don't like to spend too much time just kind of trying to figure things out and, you know, just doing little things to try to make people better. We send you early, and if it's too early, that's okay. But if it's too late,
It'd
that's
be
never
too
good.
early.
Exactly.
So,
But it's still a challenge.
but,
it's still a challenge.
but see, I was sick. I mean, I was throwing up.
Right.
I never heard of throwing up being a sign of having a heart attack. I mean, I couldn't keep my dryers quit working that morning. It's caught on fire. My son and I were trying to get it out of the house. I just thought I got a little smoke in me because it caught fire, and so that. And I'm throwing up. She after about 9 o'clock at night says, "I'm taking you to the hospital because something's wrong." But I didn't know throwing up was.
that's very common for patients
But
to
I mean, I
kind of
never
blame
heard that.
other things for their symptoms.
Exactly.
So.
Well, I mean, if it hadn't been the fire that day, I wouldn't have thought about it.
Exactly.
That is true, and that's with a heart attack. But the same thing with heart failure, like I was saying. You know, most doctors think of heart failure only when people have so much swelling and they have fluid in their lungs and so on. And the problem is a great many people these days don't exactly have that. A great number of people will have more subtle symptoms. They have no energy, can't do anything, get easily tired, you know, can't eat, you know, things like that. When more 90% of the time people miss it, or you're coughing, so you know it's bronchitis, so you
Right.
get put on courses of antibiotics before somebody even recognizes that it's the heart. That is the problem, and even now it's still a challenge when with a lot of the doctors around here, and you can imagine at least when I talk to people. But it's even worse if you go to like Lake Wales or Bartow or somewhere else. It's even more difficult because the doctors don't think that their patients are that sick, because they think, oh yeah, he had a heart attack 2 years ago and his heart function is 25, but otherwise he's doing great. And oftentimes if you ask the person, if you actually talk to the person says, well, I can't walk, maybe I can walk to my mailbox and come back, but otherwise I get easily tired. And those are all subtle signs that you can see before they get to the point where it's so bad that they need a VAD. It's recognizing those.
Absolutely.
And we get the rest of the staff. Some staff are here. If any of you come here, you'll see there's Stephanie and Connie and Rose is outside.
So we rely a lot on our teamwork because, as you all know, this is a very complex disease, and it's not always just cut and dry. So we spend a lot of time like coordinating care, checking on patients. We have set up where the patient can get in to see us very quickly. Most times it's very difficult to get into a doctor if you need
That's
them.
another problem.
So we have like same day, next day appointments, and we pride ourselves on being able to help people when they need it. And that's our goal.
Because that's one of the common problems. One of my first patients that made me get interested was a patient like you were talking about, somebody who gets admitted to the hospital, multiple times.
Mm-hmm.
And so when she first came to see me, they said, why? And she said, well, I have a bad heart. I said, well, you have a bad heart 365 days a year. Why do you get sick about once a month? And so it turned out in her particular case, it's because once a month or once in a month and a half, she would have her grandkids visiting, and they would take her out eating, and so she'd get a little more salt and so on. But that takes time to find out those things. And that's where I got started with this, because certainly patients can spend a lot more time when they are with Cindy or staff and so on. So everybody finds out a little more. Did you know that they're doing this, or he's not doing this, and so on. And that's when the education part of it comes in. And you can figure out, are they really taking their medicines? And one of the other problems we always see is that we have somebody on a medicine, and then and some other cardiologist or another internist stop their medicine for some reason, and nobody restarted it. And these are all very common problems.
We
And
try to
see-
catch those things
They catch them
early.
early before they get sick and have to go back to the hospital. Because every time somebody goes to the hospital, it's an extra, not only forget the expense, it's extra damage to the heart. Every hospitalization worsens your heart. So that's our big push. Once you determine that it's the heart that's doing it, what can you do to make them feel better? Because I think a lot more than just survival, most patients now want a better quality of life. How can we improve their quality of life? Because these are patients who are very sick, who get very easily fatigued. They hardly can do their daily work. And so determining that is the first step. So we do a lot of that, from 6-minute walks to bioimpedance, to optimizing their medical therapy, putting a defibrillator or a biventricular pacemaker. And after all that, if they are still symptomatic, we still need to keep an eye on them. And if they are still symptomatic, then getting them to a place where they can have more advanced cares available to them, such as ventricular assist devices, transplants. Some patients are too old for any of those, and some of them may need to be in infusion therapy. And that's also an option. And finally, if they are beyond all that, then to talk to them about palliative care and hospice. All of those things are part of what